type. So congenital is obviously, as the name suggests, from birth onwards and due to endemic iodine deficiency in the diet. So if there is an iodine deficiency in the diet or if there's any defect in the synthesis, now there are many steps in synthesizing the thyroid hormone, which we've all studied in biochemistry, but we revise it. And then if there are defects in the iodide transport from the thyroid cell itself to the luminal center, that also results in primary hypothyroidism. Now, this I've put as some sort of an MCQ for you guys, Pendred syndrome. So when there is a defect in iodide being transported from the thyroid cell to the follicular lumen, along with inner ear deafness, it is called as the Pendred's syndrome. So now let's just look at the synthesis of the thyroid hormones. You can see over here that the body has, for example, you have consumed iodine through your diet. Now, the look at the left side. So you have a capillary over here. This is the bloodstream. And then you have iodide. So this is the net result of the iodine you're consuming. Now, iodide has to go inside the thyroid and inside the follicles to trigger the synthesis of T3 and T4. Okay, so then thyroglobulin is actually synthesized and discharged into the follicular lumen. And basically, that's one. The second thing that's happening inside the thyroid itself. Secondly, when the iodide is going inside, it's kind of trapped, it's actively taken up by the thyroid. I would say it's actively welcomed by the intrinsic parenchyma of the thyroid. And when it is welcomed, it is then oxidized. So it was in a sleepy state in the bloodstream. In the thyroid, it's been welcomed, it's been activated, it's been oxidized. So you have an active form of iodine. Now, when the active form of iodine is generated, it then further goes into the center, that is the colloid in the lumen of the follicle. And when it enters there, then it goes and does all this, which we have in the other table over here. So you have basically iodine that is then in its active state combining with tyrosine in the colloid, and according to the composition of the molecules, you may have diiodotyrosine, that is DIT, or MIT, that is monoiodotyrosine. So if you have one molecule of iodine combining with tyrosine, you have MIT, otherwise you have DIT. Now, MIT is the basic source for our T3 and DIT for T4. So basically, these are the main steps. This is how we're getting our T3 and T4. So what can go wrong? First of all, the iodide transport inside is affected. Secondly, the binding of activated iodine with tyrosine is affected. And third, the iodotyrosine coupling to form an active T3 and T4, that has gone wrong. So anything that is wrong in this can lead to a problem in the synthesis of the thyroid hormones and clinically manifest as hypothyroidism. Now, there are other causes. So there's autoimmune thyroid disease. So basically, this is occurring in a subset of patients where they've already taken enough iodine, but due to an immune-mediated attack on the thyroid itself, they have hypothyroidism. So that is seen in Hashimoto's thyroiditis, where the thyroid becomes rubbery, enlarged like a lymph node, and there are certain antibodies which are positive in cases of Hashimoto's, like anti-thyroid peroxidase, anti-thyroglobulin antibodies, and antimicrosomal antibodies. This is obviously another thing, that is APS1 and 2, that is part of the polyendocrinopathy syndromes, in which thyroiditis is a part. There may be iatrogenic hypothyroidism. What does that mean? That means that the thyroid is generally okay. There's nothing wrong. Everything is perfect. But because of some previous surgery, because of some radiation that the patient has received, the thyroid parenchyma has shriveled. And because of that, there is hypothyroidism. And then there can be an acquired hypothyroidism, that is basically because of drugs like methimazole and PTU. Now, we come to that category of disease. This was about, the generation of T3 and T4 and any step going wrong and you don't get the T3, T4 levels which are appropriate. But this is something else. This is when a child is born with a complete absence of thyroid parenchyma. That is called as thyroid agenesis. Secondly, there are some children in which the thyroid is present, but congenitally it is reduced in size, and that is called as thyroid hypoplasia. The third thing is that basically a patient or a person is okay, but suddenly there are germline mutations which are responsible for thyroid development. So if we look at the basic summary of causes of hypothyroidism, the two most important ones are primary, secondary. They've mentioned hypothalamic as secondary, but in further studies, you would find out that actually it's a tertiary form only. So you have all these things that are affecting the thyroid, which we've just gone through, and then the pituitary and the hypothalamus causing central hypothyroidism. So how does a hypothyroid look like? A hypothyroid patient is going to come in your clinic and he or she, most commonly it's a she because it's more common in the female gender. So there's thinning hair, especially at the outer third of the eyebrows. There is thinning hair, there is hair loss, there is slow movements. The patient is very dull, listless, and lethargic. Sometimes, the patient has puffy face. Then you have cool extremities and swelling of the limbs. Weight gain, that is a very important feature. We generally, if a patient comes to you saying that मेरा weight अचानक से बढ़ गया है, so actually T3, T4, TSH is one of the most important tests. The patient has a poor memory. So overall, you poor appetite, slow heartbeat. Overall, you can just make out that the patient's metabolism and overall functions have slowed down. Right? It's a slowing down, it's a dull, listless, puffy, idiomatous, slowed down persona. So cretinism is what it is referred to in children, and myxedema is what it is in adults. Now, a hypothyroid first presenting in infancy or childhood is a cretin. The causes are iodine deficiency, which I've explained why, and I hope you've understood why iodine deficiency is going to cause hypothyroidism. The second is there may be developmental or genetic problems, that is any germline mutation or any developmentally, as I mentioned, lack or complete absence of thyroid. Now, in some rare cases, thyroxine synthesis is defective. So what has happened is that that happens sporadically in the sense that the thyroid hormone receptors itself on the thyroid, they are defective. So the hypothalamus was okay, the pituitary was okay, everything is okay actually, except the thyroid hormone receptor. Now, the result is impaired development of bones and CNS, varying from mild to profound mental retardation. So I've mentioned, we've seen over here how it is looking like in the adult, the myxedema patient, the hypothyroid patient. But in the child, it is going to come to you as a failure to thrive, as a mental retardation, a short stature, okay? And this is cut over here, but a frequent tendency towards infections also. Now, maternal T3 and T4 cross the placenta. So we all know that the mother's hormones that are produced are going to cross the placenta. And it is this T3 and T4 that is critical for the fetal brain development. If you have a mother who has T3 and T4 that is deficient before the development of the fetal thyroid, then it would cause severe mental retardation. Now, luckily or unluckily, if that deficiency happens after the child's brain has already developed, then the child is safe. Okay, so after the fetal thyroid has become functional, then it's really not going to be too much of a problem. So Now coming to the term myxedema. Myxedema refers to hypothyroidism in the older child or the adult. As I've mentioned already, there's a slowness of physical activity, metabolic processes, and mental faculties. The patient has a reduced cardiac output, so there is decreased transcription of calcium ATPases and beta adrenergic receptor. There's an atherogenic state. Now, this is because hypothyroids have increased levels of cholesterol and LDL. There is accumulation of glycosaminoglycans and hyaluronic acid in the skin and subcutaneous tissue, which leads to a non-pitting edema. Now, what does a non-pitting edema mean? When you have any swelling, when you have any swelling in the lower limbs, just a second, just a second. Okay, so I was talking about non-pitting edema. So when you have edema in the lower limbs or any location for that matter, how do you describe edema? You describe edema as unilateral or bilateral, which site it is occurring, okay? And from a clinical point of view, you are also going to use your thumb and see whether it is pitting or non-pitting. Non-pitting edema, that, what does that mean? That means that if you're going to press your thumb onto the edematous focus, then if it is going to leave a little pit or a little gadha, then that means it's pitting edema. And if it is not, then that is non-pitting edema, right? And hypothyroid state is actually a very important cause of the non-pitting edema. Another important feature of the myxedema patient is tongue enlargement. You just tell them to show their tongue and you would see that it is enlarged. There is a deepening of the voice. There are coarse faces. So you can see over here, what do you mean by coarse faces? It's like, it's a very typical appearance. The softness, the natural softness or the natural, I would say, harmony of the face is lost because the outer third of eyebrow hair is lost, and there's a puffed out appearance, so it is called as the coarse species. How do you diagnose hypothyroidism? First of all, you're going to see the clinical features which are going to make you suspect this. The second is the lab tests, and the best test obviously is TSH. So you order a thyroid function test. In that, you get your TSH as well as T3 and T4. These are all serum tests. So you're going to collect the blood sample in a yellow vacutainer or a red vacutainer, okay, in order to get our serum. Now, free T4 level is decreased in hypothyroidism. So basically, you can see whether a patient is hypothyroid by analyzing the TSH. TSH is increased in primary hypothyroidism, but it is decreased in secondary or tertiary hypothyroidism. What does this mean? So the thyroid is producing T3 and T4. Something has gone wrong in the thyroid itself, which we know now is called as primary hypothyroidism. So there's no T3 or low T3, low T4. So that feedback inhibition on TSH is lost, and therefore TSH is increased. On the contrary, this thing won't be seen in secondary or tertiary hypothyroidism. So yes, there are other things going on. You can even ask for an ECG. So you'd see the heart rate itself is, slower than normal. Sinus bradycardia. There is a prolonged QT interval. There is flattening or inversion of the T waves, and there may be even conduction delay. So it is actually associated with disturbances in rhythm, right? Like the right bundle branch block and conduction delays. As I mentioned, the overall electrical impulse generation across the heart has also slowed down. That's why you're having these conduction delays, bradycardia, right? So that also has happened. So now you see signs and symptoms of hypothyroidism. You ask for a TFT. In the TFT, the first thing you're going to look at is serum TSH. If it's elevated, look at your T4. If it's reduced, short linear diagnosis, primary hypothyroidism. TSH is normal range, patient is euthyroid. Now, if the TSH is less, then you should actually consider a hyperthyroid state. Now, there are other things that can happen. Your TSH is elevated, but your free T4 is still within the normal range. So it's like the mayhem has just started. It's just a matter of time now. So it's subclinical hypothyroidism, and it is believed that if you have a TSH level of more than 5, you can actually treat these patients, and you can consider levothyrox if TSH more than 10. As per the guidelines are, you can even start at 5 to 5.5. You can just start it, right? So then free T4 may also be above the normal range, okay? Then it's not primary hypothyroidism, and you should actually, go in for an endocrine consultation, right, and see what could be the cause. Is there any tumor? Is there any other thing going on? So myxedema coma is a term which refers to a severe manifestation of hypothyroidism. So this may be asked actually as an MCQ. You would have a setting, an elderly lady is presented to you in the emergency. She has lethargy, she has psychosis, hypothermia, the cognitive functions have been impaired. You do the ABG analysis and you find hyponatremia as well as reduced heart rate. So that is nothing but a myxedema coma. Now, so they can give you this, and then they can also give you an elderly female, which she's presented. For example, right? So an elderly female, 65 years old, has presented to you in the emergency, and she has cognitive dysfunction, and then there is one episode of hematemesis. Then what do you think the diagnosis should be? Anybody? इसी पिक्चर में अगर हम hematemesis add कर देते हैं, so what would the diagnosis then probably be, or what should we think of? Anyone? So hematemesis is also indicative of an elevated portal hypertension. So you should actually think of cirrhosis, because cirrhosis is one of the causes of hyponatremia. Okay. Along with all this, it can cause hyponatremia. So there are various clinical permutations and combinations you should be aware of. Now let's go on to the converse, that is hyperthyroidism. Okay, so that is thyrotoxicosis. It's a hypermetabolic state, and it is caused by elevated circulating levels of free T3 and overactive sympathetic system. So just like in the case of hypo, in hyper also we have primary, secondary, and tertiary. Primary is thyroid overfunction because the thyroid itself has, some problem in it. So that's Graves' disease. Secondary hyperthyroidism is because the pituitary has started malfunctioning. There's some tumor that is secreting too much TSH. And then tertiary hyperthyroidism is when there is too much TRH. So the pathology is at the level of the hypothalamus, most likely a TRH producing adenine. So what are the clinical features on this side? So such patients you would see in your OPD, and you see that they talk very fast. They're like, the switch has been on, but it's been on in a different way altogether. So they'll be rapid talking, skin would be warm. You can get that hyperactive state. There's heat intolerance, there'll be excessive sweating. Then they may complain with, malabsorption or loose stools, palpitations and tachycardia, sometimes even tremor, irritability. Then there are ocular changes also because of the sympathetic overstimulation. So you can see that it's generally actually it's called as exophthalmos. So they have that staring kind of look, exophthalmic look, staring, wide-eyed, right? And generally it is seen that initially it is unilateral, okay, formation. So they have this. This is a completely different patient altogether. So the popping eyes, the eyes are the most important point to diagnose a case of hyperthyroid. Then they have increased heart rates, they have tremors, they, as I mentioned, diarrhea, menstrual changes, and edema, if present, is only localized, unlike the mixed edema patient where it's like all over the body. Now, yeah, so you can see the characteristic faces. एक second, yeah. Acha, okay. So then you have localized edema. Just a second, class, just a second. देखते आप ना अपने थ्योरी में हमारा सब बताते हैं तो एक काम करते हैं वॉट का तो आज देखी तो लेकिन टीवी का आज का और कल का थोड़ा हमें दूसरे सेक्शन में शुरू करो एक बच्चा वॉट करेगा और आप फिर मतलब राहुल करेगा वॉट आप ऑपोजिट करेंगे और आप इसके ऐसे डिवाइड कर सकते हैं Anji, so sorry for the interruption. Now we were talking about hyperthyroidism, so you can look at the gaze over here. Now, thyrotoxicosis, why is it occurring? It can occur because of Graves' disease, which is the most common condition in most of the cases. The second is a hyperfunctional multinodular goiter. So multinodular goiter can also be, one of this. And the third is obviously a tumor or proliferation. So you can even have a hyperfunctional thyroid adenoma. So there are uncommon causes also, which if you can remember, it would be very nice. But if you can't, that's okay. You at least remember Graves' disease, multinodular goiter, and thyroid adenoma. Okay. There is a term called as thyroid storm. Now, what is the thyroid storm? It is basically an abrupt onset of severe hypothyroidism in a patient with underlying Graves' disease. So suddenly, suddenly the patient has come with all these complaints and it is very, very severe, precipitated by stress infection. And on the other hand, there is a term called apathetic hyperthyroidism. What does this mean? This means that the patient that has come to you is an elderly patient. He has something like diabetes mellitus. So उसको thyrotoxicosis था, but then he had, a concomitant comorbid disease like diabetes, and so it has not manifested. So diagnosis of hyperthyroidism is again like hypo, based on clinical findings and confirmed by the lab test. The best screening tests are TSH, pre-T4. Here the combination is reversed. Low TSH with high FT4 gives you your diagnosis. Okay. Now, it is believed, so unlike T3 thyrotoxicosis, sometimes free T4 may behave very funny. It may actually decrease. It's not necessary that T3 बढ़ा हुआ तो जी T4 भी दोस्ती दिखाएगा. Nothing of the sort. Now, if TSH increases, obviously it rules out secondary thyrotoxicosis. It rules out anything at the level of the pituitary and the hypothalamus. This is what you have on the iodine uptake. This is normal, not thyroiditis. This is normal thyroid. This is Graves, where you have an increased diffuse in both the lobes. The intake is increased. Iodine uptake over here is very much confined to the nodule, and in some cases of toxic adenoma, actually the iodine uptake may not even be there. Okay. So now we go on to thyroiditis, inflammation of the thyroid gland. The important types are Hashimoto's, granulomatous, subacute lymphocytic, and Riedl's. On an undergraduate level, we are interested in Hashimoto's. Women are more affected by all cases of autoimmune thyroiditis, and it may be euthyroid, hyperthyroid, or hypothyroid. Radioactive iodine uptake is decreased in thyroiditis due to decrease in the hormone production. And we know that this is an entire spectrum of disease called as AITD, autoimmune thyroid disease. Now, Out of all the AITDs, you have Hashimoto's thyroiditis or struma lymphomatosa. This is the most common cause of hypothyroidism in cases where you already are taking iodine. A female age group, more common than not. Middle age to elderly, and basically a rubber-like lymph node-like a large enlargement of the thyroid gland on gross. What is the pathogenesis? So generally, thyroid autoantigens are tolerated well by the self. Here, there is breakdown in self-tolerance. Second point, so there is a induction of thyroid autoimmunity. Everybody is against the poor thyroid. So there's circulating autoantibodies against thyroglobulin and against thyroid peroxidase. इनको काम ही नहीं करने देंगे autoantibodies. Couple that with the fact that the T regulatory lymphocytes are abnormal, the sequestered thyroid is already exposed, then you have some trouble. There is genetic susceptibility also. There is belief that polymorphisms in these two genes, CTLA4 and PTPN22, is actually associated with Hashimoto's. ये आपको याद करना पड़ेगा. It's a little tough, but this is sometimes asked in MCQs. So there will be a progressive depletion of the thyroid epithelial cells in this disease because of apoptosis, and the cells die. They're replaced by mononuclear cells and subsequent fibrosis. So the pathogenesis of Hashimoto disease, you're breaking down the self-tolerance, there's an induction of the thyroid autoimmunity, CD8 cytotoxic T cells are causing T cell mediated cytotoxicity. CD4 positive Th1 cells cause interferon gamma activated macrophages leading to thyrocyte injury, and plasma cells are released which lead to ADCC. So you can just, in short, CD8, CD4 T cells दोनों ही active हो गए हैं and they have gone against their own system, right? So you have both T cell mediated cytotoxicity as well as ADCC, antibody dependent cytotoxicity. Now your gland is diffusely enlarged. It is firm or rubbery, and you can see the cut surface, which is pale. It is yellow tan, and it is nodular. So there is this massive. Now, if we look at the or we recapitulate the normal histology, which I think you're aware of, let me just go back quickly for those of you. Look at this. So over here, these are the thyroid follicles. The pale pink thing inside is colloid, and these are the parafollicular C cells, and this is the intervening blood vessel. So everything is very well behaved. You have cuboidal lining cells, and everything is okay. Now let's come down to where we were. Look at this. So over here, you have lymphoid follicles that have come out of nowhere, as if this was a lymph node. Secondly, the cuboidal cells have been replaced by clumper cells. Let's just go on higher power over here. So look at this. These are very plump looking cells. They're not cuboidal cells. They're like plumped up. This is called as oncocytic change of the follicular epithelial cells, which is characteristic of Hashimoto's. So this is actually also known by the name of the Hurdle cells. Remaining follicles are atrophic. They've already been destroyed. And at the end of all this chaos, you have laying down of fibroblasts. So this is what it is. You have a follicle, you have all these kind of plumped up cells or oncocytic change, and vis-a-vis an absolutely normal thyroid in the insect. Now, again, so this is the stage where you have laying down of fibroblasts, collagen. This is a more advanced or chronic phase. And appreciate the fact that you are hardly seeing any of the thyroid follicles. So the spectrum of AITD, it can be, your patient can actually be hyperthyroid or hypothyroid. So what does this tell us? A patient who's coming to you as a hypothyroid may actually be a case of autoimmune thyroiditis. So if the patient is not responding to your treatment initially, On the second visit, you should actually go in for an autoimmune workup. Likewise, for hyperthyroidism, treat the patient initially by, giving the anti-thyroid drugs. But then, if it's not working, then you should actually seriously consider Graves' disease. So the clinical manifestations of Hashimoto, we've already discussed the age group. She's going to have a painless thyroid enlargement in the early phase of injuries, hashitoxicosis. So it becomes very active. The T3, T4 increases, TSH decreases. And later, the classic hypothyroid T3, T4 is decreased with elevated TSH, right? So initially, बढ़ जाती है activity, बाद में कम हो जाती है. This is associated with a few malignancies which are asked again for MCQs, marginal zone B cell lymphoma and papillary carcinoma thyroid. There are other autoimmune diseases, type 1 diabetes mellitus, autoimmune adrenalitis, SLE, Sjogren's, and myasthenia. So these are all the associations of Hashimoto's. I've mentioned Hashi ke liye, you are going to go in for anti-TPO, anti-TG, right? And anti-TSH receptor actually is a part of, the workup of Graves also. Then these auto antibodies are often detected using IF. So then you have this granulomatous or decurvins is more of an MCQ. So ye to aap running though, but you can take a screenshot because you can get an MCQ based on this. So this is basically, you can see epithelioid cell granulomas with giant cell, that's deeper veins, which is because of virus-induced damages. And then you have something called silent thyroiditis, which is painless. Uh, this is beyond your Graves' disease. This is important. It's the most common cause of endogenous hyperthyroidism. Bina baat ka overactive thyroid, characterized by presence of autoantibodies against the TSH receptor. This is the main problem in Graves' disease. There are antibodies against this TSH receptor. So you have females, again, female male ratio. This one is more common in men, but not too much. It's like 7 to 10 is to 1. Uh, so basically, in fact, just a second, I'll just check this is one thing. So basically, this is a disease which is seen in the 30s to 40s, okay? 30s to 40s age group. And basically, you have hyperthyroid. That is one, we know that your patient is going to present with hyperthyroidism. Another thing is you have infiltrative ophthalmopathy. So I used, yeah, so actually it's more common. Yeah. ठीक है. So although we have an increased incidence in men, you can say female predominance. Then you have triad of hyperthyroidism, and then there is infiltrative ophthalmopathy with exophthalmos. What does this mean? As I mentioned earlier, so this is unilateral exophthalmos. The second thing that you're looking at is that on the MRI, you would actually sometimes have a compression of the optic nerve, and that is then diagnosed as a pseudotumor. The third thing is infiltrative dermopathy. There is pretibial myxedema. What does this mean? That means that the area of the shin or the area of the lower limb, just around, the skin overlying the tibia, that entire thing is very puffy. And that is again characteristic of Graves' disease. So look at this triad. Look at your antibodies against the TSH receptor. Look at the fact that it is an autoimmune disease and there is breakdown of your T cell tolerance. We are going to do antibodies against, we have TSI autoantibodies, that is thyroid stimulating immunoglobulin and growth stimulating antibodies. So basically, they are going to bind to the thyrotropin receptor, activate the thyrotropin receptor, and it is unnecessarily then going to cause increased production of your T3 as well as T4. Now, if you can look at what is happening behind the eye, that is retroorbital, you have a lot of inflammation that's also happening. which is going to release cytokines, which is going to cause your ophthalmopathy. So your antibodies that are already now present, TSI, they bind to the TSH receptor of the follicular cell. This is stimulated by an increased activation of the CAMP pathway, leading to increased levels of the thyroid hormones, and hyperplasia and hypertrophy lead to hyperthyroidism as well as thyroid gland enlargement. There is a HLA-DR3 allele association. So grossly, now look at this patient over here. You can see over here itself, look at this. There is some sort of a swelling or enlargement of the neck area. So this, and it's diffuse. You can see it here. You can see it's making some sort of a collar. And on gross, look at this. So this is soft, meaty appearance. And now look at this. So this, I've shown you the normal follicle. Now over here, it has pseudopapillary infoldings. The lining is actually projecting in the form of papillae. Colloid cracks, look at this. When there's too much of colloid, it actually cracks together. The third thing is that there is scalloping of the colloid. Look at these white bubbles. So this is because of all of the overactivity. These are three characteristic features of Graves' disease or any hyperthyroid state. Okay. Thyroid changes, we've already described what's happening in the eye, what's happening in the skin. Talked about Graves' disease. So nothing but all features that you would see in a case of hyperthyroidism. I don't think we need to go into this. This is on this discussion. And now we come to something else. There are many things over here. So we go on to this one. First. Yes. So, okay, can you see this? Can you see this presentation now?
Yes, ma'am.
जोर से बोलो बच्चों. What is this? This is nothing but the pancreatic parenchyma. You have acini and you have the islets. So this pale looking area is nothing but the islets of Langerhans, and these are all the acinar cells of the pancreas. Now, the exocrine pancreas and the endocrine pancreas are the two divisions. And we know that the endocrine pancreas is comprised of the various beta cells, insulin, alpha cells secreting glucagon, delta cells, somatostatin, and PP cells, pancreatic polypeptide, along with D1 cells, BIP. Okay. So basic and enterochromaffin cells, obviously enterochromaffin. So now normally you cannot visualize these cells individually. Okay, you have to use special stains. Either you use IHC or enzyme immunohistochemistry to figure out these cells. For example, here we've used a special stain. So all the magenta colored cells, they're actually nothing but beta cells. Okay. So आपको, if we go back over here, look at the islets. आपको नहीं समझ में आएगा कि which one is a beta cell. So then we put up a special stain and then we find out. Okay. So now talking about diabetes mellitus. Diabetes mellitus is nothing but a group of metabolic disorders. The common denominator is hyperglycemia. Why is this hyperglycemia occurring? It is occurring because of a defect in insulin secretion. Now we know that insulin has an effect of hypoglycemia. It reduces the blood sugar. So if you don't have enough insulin that is being produced in the body, or secondly, if insulin is being produced in the body but it is defective structurally, then your diagnosis is diabetes mellitus. Now, chronic hyperglycemia and its metabolic effects, they affect multiple organ systems. So in short, Diabetes is actually a multi-systemic disease. There's lots of people of diabetes in this Asian continent. And now, if we look at what are the diagnostic criteria for diabetes, in 2018, the ADA, American Diabetic Association, they came up with the diagnostic criteria. And still then, these are the criteria that are being followed only. So you have fasting plasma glucose of more than equal to 126. Before starting this, I'd like to tell you a few things. Blood glucose is collected in the SF vial, which is a grade of Vacutainer. SF vial means sodium fluoride Vacutainer. Why are we using sodium fluoride? Because it inhibits enolase, and therefore you do not get a false. See, अगर हम EDTA में डालेंगे blood, you know, then the blood, because of the activity of enolase, you won't have any sugar to count. But then if you send it in a sodium fluoride vial, that inhibits the enolase and you have accurate values of blood sugar. So that is how you're going to send the sample. The second thing is, what is the second diagnostic criteria? You have a patient who already has classic symptoms of hyperglycemia. However, when you did a random plasma glucose, you saw that it was like way above, more than 200. 2-hour plasma glucose is more than 200 during an OGTT. And then this one, I would say the first and the fourth. These are the criteria that are used in modern medical practice. So HbA1c should be more than equal to 6.5 to make a diagnosis of diabetes. Now, HbA1c is a marker of long-term glycemic control. That's one. So, all tests except random blood glucose in a patient with classic hypoglycemic signs need to be repeated. What does this mean? This means if you've got a patient, you've taken the blood test and you've got a value of, say, 132. Are you going to diagnose the patient as diabetes? No. You are going to have to repeat the test once. So if you have, and obviously not on the same day, on a separate day. So you need at least, two tests that are confirming your results. Now, sometimes what happens is, let's go back. Sometimes you have got 132. Either आपका HbA1c is not elevated. What are you going to do? Which one is valid? You'd still consider any one of the two tests, abnormal tests, to be valid. And in the case both are abnormal, what you are going to consider is, for management purposes, कौन सा test ज़्यादा गड़बड़ है. So result with greater degree of abnormality is considered valid. Now, before making the diagnosis of diabetes, you have to be very careful that the patient in front of you should not have any infection, should not have any fever due to any other reason, should not be post-surgery, should not have burns or something that is naturally going to lead to a transient elevation of the blood sugar. So, as a clinician, it's your duty to diagnose hyperglycemia, which is persistent when there is no acute illness. So that is the most important thing, to diagnose it. Now, there are certain things that you should know apart from this, and that is the IGT, pre-diabetes. The people who are at risk get a fasting plasma glucose. And then when you realize that the value is between 100 and 125, then it is called as impaired glucose tolerance, or IFG, impaired fasting glucose. Then you have cutoffs for everything. So if your 2-hour plasma glucose is between 140 and 99, after a 75-gram load on the OGTT, again, this is pre-diabetes. And when your HbA1c values are between 5.7% and 6.4%, it is a pre-diabetes. Now, by the way, HbA1c is a test of hemoglobin electrophoresis. You may be asked, on hemoglobin electrophoresis, which peak is representative of HbA1c values, and your answer is P3. अभी तो ये लिख लो MCQ के point of view से. I can teach you later when I finish all this, right? So P3 peak is indicative of HbA1c. Then you classify diabetes mellitus. So type 1 diabetes mellitus is nothing but basically immune mediated. मतलब वो destruction हो रहा है आपके cells का. The immune system has destroyed the cells, destroyed the beta cells also, and therefore there is a lack of insulin in the body. Now, type 2 is insulin तो ठीक ठाक बन रहा है, but it is not able to discharge its duties properly. So there is resistance and there is beta cell dysregulation. वो भी ठीक है, but in the sense कि they are okay in numbers, but they're functionally not working properly. So there are various categories of diseases that can be associated with type 2 diabetes mellitus. And the third category is basically gestation. So diabetes kabhi tha nahi, but pregnancy has triggered the development of diabetes mellitus. So now coming to genetic defects of beta cell function. So we just go into this again. So type 1 is clearly immune mediated and it's a different story altogether, and it's generally seen in the younger age group. Now we talk about type 2, in which we have all these genetic defects of beta cell function, right? So maturity onset diabetes of the young. So basically you have all these genetic defects, MODY 1 to MODY 6. Then you may have KCNJ11, ABCCA. These are all genes which you'll unfortunately have to remember. These are genes that are associated with the development of diabetes mellitus. Then there may be genetic defects in insulin action. There may be some. Now, this was just about the endocrine portion. What happens if the exocrine portion, that is the pancreatic acinine, उधर कुछ गड़बड़ हो गया? So if there's chronic inflammation in the neighborhood, chronic pancreatitis, if the pancreas has been removed altogether, if there's a tumor in the pancreas, if the secretory activity of the pancreas is not okay because of cystic fibrosis, if there is deposition of iron in the pancreatic acinine, as in hemochromatosis, or if there is deposition of fibrosis, pancreas का overall health तो ठीक नहीं है, which is associated with the development of diabetes mellitus. Then, as part of various syndromes, it may be associated with other endocrine abnormalities. This you need not remember. This is just the cause, the settings in which diabetes mellitus can develop. There are various infections which are associated specifically with the development of diabetes. So these are the 3 C's, as I call it, CMV, congenital rubella, and Coxsackie. Now, drug-induced. As I said, this is a very long lecture today. And you keep on drinking water, otherwise you'd fall asleep, because actually it's a very extensive topic. Now you have drug-induced diabetes mellitus. So there are various drugs that you can consume that can also interfere with the secretion of insulin. So out of these, the most important, this is a large list, okay, fine. But the one you should remember is glucocorticoids. Why? Because nowadays you have so many immune mediated diseases in which the physicians are going to prescribe steroids. And because of long-term intake of steroids, it is seen that you have diabetes mellitus. So that is one drug you must remember out of the list. Second, I would suggest remember thiazides, is diuretics. Third, you can remember thyroid hormone. And fourth, phenytoin. These are the drugs that are associated with diabetes mellitus. Certain genetic syndromes associated. So you could get an MCQ out of this. Any 3 options or 4 options, 3 options could be given and then one other option, okay? So how does type 1 diabetes mellitus develop? As I mentioned, it's an immune-mediated disease. The islet cells are destroyed and it can develop at any age, but more in the younger age group. Then it is involving an interplay of various genetic and environmental factors. So Type 1 diabetes is a combination of a genetic predisposition as well as environmental factors which have caused autoantigens to form on the insulin producing beta cells. This results in presentation of autoantigen by the APCs. Now the T helper lymphocytes go berserk. We have already studied multiple times what happens when T helper cells go berserk. You have interferon gamma production, which results in activation of macrophages and release of our two favorite cytokines, IL-1 and TNF-alpha. What else happens? IL-2 can be produced, which is associated with your CD8 T cells. Then you have activation of T helper. So T helper 1 काफी नहीं है, दोनों ही activate हो रहे, leading to IL-4 activation and the B lymphocytes are activated. Why are we interested in knowing this? This is very important. Out of all this stuff, there is one MCQ that is definitely asked, and that is islet cell autoantibodies in the diagnosis of diabetes as well as anti-GAD65 antibodies in the diagnosis of diabetes. So when you get these antibodies, you diagnose it as a case of type 1 diabetes mellitus. Net result of all of this is destruction of beta cells, decreased insulin. So as I mentioned, there is something wrong in the genes or there's something wrong in the environment. What can go wrong at the genetic level? There are a number of susceptibility loci for type 1 diabetes. HLA gene clustering on chromosome 6 is the most common. So then you could be asked, what is the HLA cluster that is associated with diabetes? One is DR3 or DR4 haplotype. Then there could be a number of tandem repeats of variable length sequences in the promoter region of insulin gene. I've already mentioned these two, CTLA4 and PTPN22. Ye yaad karna. This is very important for diabetes. Environmental factors. You have any viral infection, it's going to trigger an autoimmune response, as we've already read earlier, molecular mimicry and destruction of the islet cells. So look at this, beta cell mass here, time span here, and over the time, the patient's beta cell mass has reduced. And over here, you can see overt diabetes. The fundamental immune abnormality is a failure of self-tolerance. Now, by the way, diabetes mellitus is a topic which you should know from A to Z, start to scratch. And the pathogenesis is asked. You could be asked the types of diabetes mellitus, that is, classify or enumerate the types of diabetes mellitus. What are the diagnostic criteria for diabetes mellitus? What is the pathogenesis of diabetes mellitus? So in that, you are going to actually deal with type 1 and type 2 separately. Type 1 being an autoimmune disease. You would mention this entire chart over here. This is nothing but the pathogenesis of type 1 diabetes mellitus in very short. And you can mention that. Jitne diagram banao utna acha hai. Then after that, you can say that the fundamental immune abnormality in type 1 is a failure of self-tolerance. We've already discussed that. Defective clonal deletion. So जो गड़बड़ cell है उनको हम निकाल नहीं सकते. So there's defective clonal deletion of self-reactive T cells in the thymus, as well as defects in the function of Tregs. तो आपके जो Tregs हैं वो भी defective है. The third thing is the T cells that have gone berserk, they are surviving. Or in turn, they're irritating the B cells, they're destroying them also. Then I've already mentioned of the islet autoantigens, which are targets against insulin, GAD, and ये भी important है, ICA512, Fogrin and zinc. So इनमें से कोई भी जो अगर होता है, so this leads to the diagnosis of type 1. Now coming to the pathogenesis of type 2. How is this happening? Same funda, genetic factors as well as environmental factors. Now here, the main environmental factor is not the viral infection. The main environmental factor is कि patient obese है आपका. Lifestyle problems, as a result of which insulin तो बन रहा है, but the insulin is not functioning properly. There is insulin resistance, as a result of which the beta cells are struggling. And when they're struggling, they try to compensate. They try to make good insulin, but they're still unable to do so. So normally, initially, patient is still normoglycemic when the compensation is happening. But with time, the beta cells fail. With time, you develop IGT or impaired glucose tolerance, and then subsequently, the patient develops diabetes, frank diabetes. Okay, so this is how it progresses. So it is very important to note that type 2 diabetes mellitus is nothing but a pro-inflammatory stage. Now, how is that going to happen? Type 2 diabetes mellitus is happening in an obese patient. Obese patient is having more lipid cells, more adipocytes. Now, it is believed that adipocytes are actually a source of three things. One is adipokines, one is free fatty acids, and actually they promote inflammation. Now, the net result of all of this is an insulin resistance. So over here, you can see in this chart very nicely how the beta cells have started compensating, and ultimately they say enough is enough. We can't do more than this, and they start decreasing in number. So there are metabolic defects, insulin resistance, and general beta cell dysfunction. So what is this insulin resistance? Bun to rye, but there's a decreased response of the peripheral tissues to insulin. There is inadequate insulin secretion in the face of insulin resistance. तो beta cell अपने आप उनका function भी गड़बड़ हो गया, and this we've already studied. So with the insulin resistance, what happens next? There is failure to inhibit gluconeogenesis in the liver. Liver तो अपना blood glucose बनाए जा रहे हैं. Second thing is there is failure of glucose uptake and glycogen synthesis happening at the level of the skeletal muscle. इससे क्या होगा हमारा? इससे blood में glucose रहेगा, पर जहां जाना था उनको, the blood glucose had to be delivered to the muscles. वहां वो जा नहीं रहा है, so the bloodstream में blood glucose बढ़ गया. Now the third thing is failure to inhibit lipoprotein lipase in the adipose tissue. This results in increased FFAs, worsening, compounding the problem. If that was not enough, we all know that insulin binds with the insulin receptor. उसके alpha subunits होते हैं, beta subunits, and all the pathways mediated by tyrosine kinase. We know all this. Now, in insulin resistance, the insulin signaling pathway itself is defective. So there's decreased tyrosine phosphorylation of the insulin receptor, and IRS proteins is observed in the peripheral tissues, compromising the insulin signaling. Now, उससे क्या होगा? Insulin signaling अगर गड़बड़ होगी, so there's a reduced level of GLUT4 car. I call it the GLUT4 car. तो इनकी गाड़ी खराब हो गई है. It is reduced on the cell, and so the glucose transport also is being affected. Now, it is believed that if you have a paunch, it's not in, but otherwise it's not in also because central adipose tissue is more lipolytic than peripheral adipose, which explains why if endocrinologists see this, they actually become very worried. So excess FFAs, they overwhelm the oxidation pathways leading to accumulation of DHEs, and these are toxic products which itself disturb the insulin signaling. What are adipokines? Absolutely, absolutely. So what I want to tell you over here is we know, let's look at this diagram. We know that adipose tissue is comprised of adipocytes as well as blood vessels, right? Now, these adipocytes, they are a source of adipokines, which I'm about to explain, and free fatty acids, which we know about. Now, we are interested in figuring out what is happening at the peripheral and the central levels. So if you have belly fat, it is believed, scientists have figured out that the adipocytes in abdominal fat, they have a tendency of being more susceptible to destruction and weakening of their membranes, releasing more of free fatty acids into the bloodstream. These are the adipocytes that are present, say, at locations like my shoulder or somewhere in the periphery. So their tendency of releasing free fatty acids is less as compared to an abdominal fat adipocyte. I hope that's clear. Right. So then we talk about adipokines. Now, what are adipokines? Adipose tissue itself, it's not just about the structure of the vessel and the adipocyte. It is a serious business. It's adipokine. It is a function. It is believed that it's a functional endocrine organ itself, and it is secreting a number of proteins into the systemic circulation. So some of them are going to promote further elevation of the blood sugar. Okay. And some of them, like leptin and adiponectin, they are going to decrease the blood glucose. Now, how are they going to do that? They are going to actually help out by increasing insulin sensitivity. Now, obesity actually decreases the adiponectin. Okay. Now, and because of a reduction of the leptin and adiponectin levels, you have it's sort of a left-handed theory. So you are increasing the insulin resistance. I mentioned this prior also. There is, if you look at this diagram over here, I like this diagram actually. So I'm going back again. You equate 15 points as adipokines, FFAs, and inflammation. So these adipocytes are actually pro-inflammatory. So they are going to secrete cytokines also. Free fatty acid to bana hi raha hai, but at the same time, it is going to produce all these molecules like IL-1B, TNF alpha, all the cytokines we've read up. These are all being released in type 2 diabetes mellitus. Right. So now let's just look at what I want you to draw this diagram if you are asked type 2 diabetes mellitus pathogen. Look at what all is happening to the beta cell. A beta cell jo hai, it has dysfunction, right? So it's not functioning properly. What is actually happening over here? Excess free fatty acids that are present in the bloodstream, they actually compromise the beta cell function, and this thing itself by which your FFAs are telling the beta cells to hang on, you can't work properly. This is called as lipotoxicity. It is reducing the insulin release, not interfering with the job. Second thing is, बहुत time long standing there's hyperglycemia, and this is leading to a second effect, and that is called glucotoxicity. And the third thing is there is incretin. Incretin also is a molecule abnormally which is being produced in diabetes, which is reducing the secretion of GIP and GLP-1 hormones that promote the insulin release. Now, if you look, so over here, lipotoxicity, glucotoxicity, we talked about insulin resistance, we talked about, yeah, so amyloid being deposited in the islets. This is also another trouble that is happening in the case of type 2 diabetes mellitus. Okay, so this is one other point. Right. So then we have various drugs that can also cause diabetes mellitus. Then, yeah, so this LADA. Now you say what is LADA? भाई ये भी क्या चीज़ है भाई? So this is latent autoimmune diabetes. Okay, latent autoimmune diabetes, which is seen in adults. And this is nothing but a form of autoimmune diabetes, right? Now you'd say कि ये autoimmune diabetes तो हमने पढ़ा है कि ये तो type 1 diabetes का feature है. So what about this type 2? So this is actually a special subset in which, the autoimmune beta cell failure is actually very slow. The beta cell dysfunction है ये, but it is so slow to progress. It can take up to 12 to 15 years until the beta cells actually fail. So this has also been put under the category of a beta cell dysfunction only. Monogenic forms are talked about MODY 1 to 6. and various single genes. So जहाँ पे भी only one gene is involved in causing diabetes, it's called as a monogenic form. So I think you can just put this kind of heading and describe it. So what else is happening? So yes, there are others. So up till now, we were talking about what is happening inside the pancreas, what is happening at the level of the islets, what is happening at the level of the immune response in type 1. And over here, we were talking about what is the free fatty acid and inflammatory cytokines. But there's another angle, and the other angle is what is happening in the tissue. So there are genetic defects that can hamper our tissue's response to insulin altogether. Okay, so basically, you can have impaired receptor synthesis, impaired binding at the level of the organs in a setting of hyperglycemia. Then there are certain skin changes that are associated with diabetes mellitus, like acanthosis nigricans. Look at this. So you have, I won't call it velvety, I will multiple folds actually, lipoatrophic. So the shriveling sometimes of the fat altogether. So you can see many diabetics who are actually give that very cachexic look, right? So all these features they can be associated with diabetes. Now, yes, this is the third type, that is gestational diabetes, pre-gestational. The lady already had diabetes, right? So if she's pregnant, that doesn't have very, it's not relevant. Now the problem is when we have women who were previously okay, but suddenly they develop diabetes for the first time in their lives. So gestational diabetes mellitus is diabetes that has first been diagnosed in the second or the third trimester of pregnancy, and it is not clearly either type 1 or type 2. That means that you can get overlapping features of both. Pregnancy actually is a diabetogenic state. Matlab, it is a state that naturally favors insulin resistance. So in your Viva, you can be asked, how is pregnancy a diabetogenic state? Well, you have the human placental lactogen. It has anti-insulin effect. It has a lipolytic effect, increasing the glucose levels and making more glucose available to the fetus. The excess of steroid hormones that are being produced, they also have an anti-insulin effect. And some insulin is destroyed, sorry, by the placenta. Net effect is macrosomia, large baby, stillbirth, or congenital malformations. Typically, it would resolve following delivery. However, there are some unfortunate women in which, over the next 10 to 20 years, they actually develop frank GDM. Now, clinical features, your patient is coming to you with complaints of polyuria, polydipsia, and polyphagia. Polyuria means frequent urination. Polydipsia means a lot of thirst going on, and polyphagia means always feeling hungry. So, why is your patient, complaining of polyuria? That is because the utility of glucose has sharply been affected. Hyperglycemia to hai, but the utility, the transport system into the muscle adipose tissue, that has been affected. Right? So the existing reserves are depleted by glycogenolysis. Resultant hyperglycemia has pushed up the renal threshold for reabsorption. You get glycosuria. And because of that component, of solute, which is going in the urine, it is going to induce an osmotic response, osmotic diuresis, leading to polyuria, which is going to lead to a profound loss of water and electrolytes. Just a second, I'll just ask for my charger. Just a second. So now we are going to talk about why do you have polydipsia? right? So polydipsia is frequent thirst. You feel thirsty all the time in diabetes. Why is that happening? It's because renal water loss with hyperosmosis. Now we know why the osmotic diuresis and all that has happened. So you have increased levels of glucose in the blood, hyperglycemia, depleting the intracellular water. Okay. And this in turn triggers the osmoreceptors of the thirst centers of the brain. So you continuously feel thirsty. Now, why do you feel hungry? This is very easy. Insulin deficiency is going to promote a breakdown of your proteins and fats. And when this breakdown happens, then gluconeogenic amino acids are released into the bloodstream, which are removed by the liver and used as building blocks for glucose. So the catabolism of proteins and fats tends to induce a negative energy, and the patient always wants food because itna sab breakdown ho raha hai. So the patient feels tired all the time. The appetite is increased. The patient is cachexic. Now let's go on to the complications of diabetes. They may be acute or they may be chronic. Now, what all can happen? Explaining to us this chart of Robinsky, how do you get polyphagia and the ketoacidosis and all this. So the acute metabolic complications, diabetic ketoacidosis, hyperosmolar, hyperketotic osmolar coma, and hypoglycemia. So what is all this about? You get an MCQ very frequently, and you may also get a card on this in spotting. So you have a 40-year-old person who has come to you. He is a known case of diabetes. He has missed his insulin dose. Or, secondly, he has had a viral infection. What happens next? Basically, because of missing the dose, your bloodstream is going to have more of glucose, which is going to shoot up. And this is actually going to promote a release of the catecholamine epinephrine, which blocks any residual insulin action. जो action था वो भी block हो जाएगा. Now, what else is happening? Because of glucagon excess, the peripheral utilization of glucose has decreased while the gluconeogenesis is still on stimulation. The result is a severe hyperglycemia. So the classic clinical setting would be 40-year-old patient coming to you, infection, viral infection, missed dose, and severe hyperglycemia. So you have like 400 to 500 K level में plasma glucose. So how does the ketogenic machinery get activated over here? Your insulin is deficient. Lipoprotein lipase is in effect activated state. Adipose tissue is broken down. Free fatty acids are there in the bloodstream. They are going to be esterified. Acyl coenzyme A, ketone body production. If the production is more than the utilization, obviously we're going to get ketonemia and ketonuria, and that is why we test for ketone bodies in diabetes. Now, this is the other clinical setting, that is HHS. So you have now a 70-year-old gentleman who's come to you, is a diabetic, left alone by the children, typical clinical history bata rahe, not looking after himself, disabled by stroke, has an infection, and he's unable to look after himself, so he's unable to maintain adequate water intake. उससे क्या होगा कि there's severe dehydration because इतना सारा osmotic diuresis हो रहा है and he's not able to compensate by taking it through oral mode. So because of all this, what happens? There's an absence of ketoacidosis and its symptoms. The patient has delayed seeking medical attention, and the hyperglycemia in this case it shoots up even more. So आपका जो blood glucose that is like 800, 900. Now look at this chart is master chart. So HHS is in the older age group, type 2. Here it's in the younger, type 1. And over here, as the name suggests, in ketoacidosis, your pH would be less. In HHS, the pH would be more. Then you can see over here, look at the glucose levels. So HHS diagnose karna hai when you get a value of like 700, 800, okay? So, and then ketones, as the name suggests over here, their ketoacidosis में बहुत ज़्यादा होता है, इधर नहीं होता. And the mortality is you could say these cases are very severe HHS ones, okay? And they're very difficult to manage because they already have many comorbidities. So these were the acute complications, DKA and HHS. Now chronic complications. So long-term complications, sustained hyperglycemia leads to the formation of advanced glycation end products. What is this? You have more glucose in your body, in the bloodstream. There is a non-enzymatic reaction between the intracellular glucose derived dicarbonyl precursors with amino groups of both the intracellular and extracellular protein. Nothing to worry about. समझने की बात है ये. You have more glucose in your body, which has been lurking around for a long, long time. अब वो खाली तो नहीं बैठेगा ग्लूकोज, gonna interact with the neighborhood. तो जो आपके आसपास के प्रोटीन होंगे इंट्रासेल्युलर एज वेल एज एक्स्ट्रा सेल्युलर उसके साथ दोस्ती बनाने की कोशिश करेगा. So that is a non-enzymatic reaction that is happened, which leads to the formation of advanced glycation end products. And this is something which in turn has procoagulant effects and can lead to other effects in the body. What else is happening? There is the protein kinase C activation. Okay, protein kinase C activation, which is leading to defects in the vessels and the nerves. उनका भी degeneration हो जाता है. And all these molecules over here on the right side, they're involved with blood vessels. So they get upregulated or ये सब गड़बड़ हो जाता है. So vessels and nerves start malfunctioning. Now then you have polyol pathway disturbance. Nothing. So basically you have increased glucose and under the influence of your aldose reductase and NADPH, you have conversion into sorbitol. Okay, so sorbitol is then further metabolized into fructose. So basically, hyperglycemia induced increased flux, and when you have more of fructose, have more proteoglycans because fructose is actually a substrate for the glycosylation of proteins. So you have lots of end organ damage. Now we quickly go on to the morphological changes. See, what do you expect? In the pancreas, in type 1, your islets are going to be reduced in size. Cells themselves are going to be reduced in number. Since type 1 is an autoimmune disease, आपको lymphocytes भी neighborhood में मिल जाएंगे. In type 2, there would be a reduction in islet cell mass, but beware. In type 2, ऐसे भी हो सकता है कि in the compensatory phase, there would initially be an increase and then there's a subsequent reduction. Third thing is you have amyloid deposition, which I mentioned in type 2 diabetes, right? And then in diabetics, it is seen that actually there's a characteristic increase in the number and size of, so this is a different histological feature seen in gestational diabetes. So over here, look at what has happened to the poor pancreas. Look at the acids, they're all shriveled up. There's just lymphocytes that remain, amyloid deposition in the islets, and that's about it. All the cells are gone. See, look at these purple dots, lymphocytes that have infiltrated the pancreatic parenchyma, right? Now, so this is, one thing. Then you have macrovascular disease. What does this mean? The vessels in a patient who has diabetes, the vessels themselves are gone. So there's endothelial dysfunction. The patient has more susceptibility to atherosclerosis, and because of that, more susceptibility to stroke, to MI, to acceleration of atherosclerosis, leading to gangrene of lower extremities. Now let's look at this. This is a section from the kidney. With a देखो. So you have your renal vessels. Either look at the diameter. ये इतना मोटा हो गया. This artery over here, this arteriole actually, it's sclerosed. So hyaline deposition of material outside and inside the vessel, which is actually even compressing the glomerular loops over here. Hyaline arteriolosclerosis. So this is what is happening in the large vessels. What is happening in the small vessels? Diffuse thickening of the basal membranes. The leaky. And this is what is behind diabetic nephropathy, retinopathy, and even neuropathy. So, to summarize, what is happening in the smaller blood vessels? You have chronic hyperglycemia. Your basal membrane proteins, they're going to be glycosylated because your glucose in the bloodstream is interacting with all the proteins here and there. Your blood vessel is going to be leaky and there's going to be deposition of matrix proteins. So look at this. Look at this over here. Your vessel is leaky. The glucose results in glycosylation, and you have your advanced glycation end product release. Now look at this. On the left, you have what you call as a Luxol fast blue stain. This is going to highlight the myelin sheaths of all the nerves. So you can see these circles over here on myelin sheaths. Either they on the right side, कहाँ सब चले गए. So there's nothing. So there's a complete loss of the nerves. ये जो भी छोटे मोटे रह गए इधर, so you can barely see. So it's a completely destroyed kind of thing, and this is common with diabetes. Right now, diabetic neuropathy. So we all know that there's non-enzymatic glycosylation because of the friendly interactions glucose is having in the neighborhood. Age aa jata hai when you have your excess glucose converted to sorbitol, increased osmolarity and reactive oxygen species. So इधर देखो और भी अच्छे से पता चल रहा है इसमें because उधर तो on the right side you had all the nerves lost. Here, look at this. There's some nerves that are okay and some nerves that look at this. Look at the diameter. Look at the shriveling. Hmm? So it's completely gone over here. And you can even look at this. This is a vessel which has been thickened, right? And you have reduplication of basal membrane. The nerve fused basal membrane itself has been reduplicated. How is the patient going to present? Patient is going to say, मेरे को numbness हो रही है, मेरे को sorry, मेरे को numbness हो रही है, मेरे को balance में disruption हो रही है, and there's autonomic dysfunction. I mentioned that because of sorbitol, there's cataract formation, glaucoma, and diabetic retinopathy. So if you do a fundoscopy, you see dot and blot hemorrhages. So what is a dot? This is the optic nerve disc, by the way. So I've used a fundoscope, and I am examining now the fundus of the eye, the optic disc, basically. Look at this red dot over here. So this is a dot hemorrhage. And look at this over here. It's a big kind of red dot. It's called a blot hemorrhage. These yellow things are called as exudates. And then जब ये बड़े हो जाते हैं, when they become very, very big, so then they're called as cotton wool exudates. Okay. So over here you can even see the aneurysm around it. So basically ये vessel जो है वो अपने आप में dilate हो गई. You can just remember dot and blot hemorrhages along with exudates. Now, very long, must say, diabetic nephropathy. Now the kidney is also gone. Any pathology of the kidney is divided into four compartments: GTI, glomerular, tubular, interstitial, and vascular. So in the glomerular lesions, we know very well that we have a number of changes. Vascular lesions like arteriolosclerosis and pyelonephritis, we know includes necrotizing papillitis. So the capillary basal membrane has been thickened over here. So there's widespread thickening of the GBM, widespread thickening of the tubular basal, which is highlighted on past stain, क्योंकि ऐसे आपको पता नहीं चलेगा. Third thing is diffuse mesangial sclerosis, diffuse increase in the mesangial matrix, which again is past positive. So a normal mesangium actually has like 3 to 4 cells only. Here you can see that this entire area has expanded. Mild proliferation of the mesangial cells is a feature of the normal disease process, early disease process, but later on, it actually can form nodules. So now I'm going to show you something else. Look at this. So this is actually an ovoid or spherical matrix nodule, which is seen at the periphery of the glomerular tuft. It is past positive, and it is because of a destruction, ultimate destruction of the mesangium with fraying of the mesangial surface. right? So this is known by the name of the KW lesion. So these are nodular lesions. Now somebody may say amyloid क्यों नहीं? You do the amyloid stain और सारे negative आएंगे इसमें, okay? This is how you differentiate. Then pyelonephritis, look at this. So you have a papillae, renal papilla, entire thing has been necrosed. You have a nice yellow area. Look at this also, necrosis. Hmm. So all these features are happening because your vessels are not functioning properly. The vascular supply is compromised. So you have MI, you can have stroke, you can have renal vascular insufficiency, nephropathy, neuropathy, visual impairment, increased susceptibility to infection. So these are all of the complications that can happen in diabetes, right? So somebody may ask you, I'll repeat the questions. How do you define diabetes? What are the diagnostic criteria for diabetes? How do you classify diabetes? What is the pathogenesis of diabetes? What are the morphological changes you can see in diabetes? And then what are the complications of diabetes, which may be metabolic, which may be acute, and which may be chronic? Now, if that was not enough, this is quite a marathon, I'm telling you. There is another one coming. So it's the last one, and I fatafat karni isko. So this is the big one, and it's the most important one. So here we go. You can see this one now.
Yes, ma'am.
Right. So now how are we going to diagnose this? Our diagnostic tests can be screening. They can be confirmatory. They can be analyzing a long-term glycemic control. Fourthly, to analyze the acute complications. Fifth, to look at the long-term complications. And sixth, if there are any specific types, like in DN type 1, we would like to analyze some specific genes. So you can classify all the tests in these categories. Already discussed what are the diagnostic criteria in 2018, which still are valid. Now, what are the other definitions we've talked about? IFG is between 100 and 125. IGT is actually defined when you do a 75-gram standard OGTT. And if your 2-hour plasma glucose is between 140 and 99, then it's IGT. And pre-diabetes A1C, we've already discussed 5.7 or 6.4. So when are you interested in screening for DN? Basically, if you have an overweight or an obese adult, having one or more of the following risk factors, so a patient who has a first degree relative with diabetes, ethnic group also which is susceptible, a patient who has cardiac disease, hypertensive, increased HDL, just a sec. राना साहब मेरी क्लास चल रही है मैं 10 मिनट में कॉल करती हूँ आपको. So then we have, so we have women with polycystic ovary syndrome, physical inactivity. So if any one of these things are applicable to any one of us, yes, we should go in for a screening of diabetes. Patients with pre-diabetes, they should be tested yearly for diabetes. Women who are diagnosed with diabetes during pregnancy, you should screen them throughout their lives for at least every 3 years. For everyone else, start from the age of 45. If the results are normal, repeat testing should be minimally at 3-year intervals and more frequently depending upon your clinical judgment. I've already mentioned this is an autoimmune disease, and basically we should be using blood glucose rather than A1C to diagnose the acute onset of type 1 diabetes. Secondly, the screening for type 1 diabetes with autoantibodies is done. So जितने भी genetic tests हैं वो तभी किए जाएंगे when you have a family member who already has diabetes. And that too type 1 diabetes. The third thing is that if there's a persistence of 2 or more autoantibodies, it predicts clinical diabetes. So if someone in the family has type 1 diabetes, go in for these tests. And if you have these autoantibodies, obviously, it calls for clinical intervention. Now, ADS said, are you at risk for type 2? So obviously, this is the kind of questionnaire that is there. How old are you? So the age, the gender, and GDM, and whether there's anyone in family, physical activity, as well as your weight and your blood pressure. Now, the criteria is again over here overweight. So that is defined by the WHO's BMI more than 85th percentile. Plus, for type 2, if there's anyone has a maternal history of diabetes, a family history of type 2 diabetes, a race or ethnic predisposition, insulin resistance, and then anything in the metabolic syndrome, hypertension, etc. Now, so how are we going to do this? Plasma glucose and the OGTT. The word fasting means when you don't have any caloric intake for at least 8 hours. Random is when there's no regards to the time since the last meal. Monogenic is जब एक कोई भी gene involved है. So all children diagnosed with diabetes in the first 6 months of life should have immediate genetic testing for neonatal diabetes because this is not the age group for diabetes. Now, this is too less. So, therefore, go in for genetic testing. Those children and adults also in early adulthood who have diabetes, but आप किसी भी type में उसको fit नहीं कर पा रहे. You're thinking इसका भी feature है, उसका भी feature है. Go in for genetic testing. I've already mentioned the color of the vial. This is the SF vial. Fasting key value normally 70 to 110 OPA. We are diagnosing diabetes at more than 126. Postprandial means after lunch or after dinner, after meals, basically. So 110 to 140. Then plasma estimation is preferred. Whole blood glucose हमें नहीं लेना, so you have to wait for the separation basically. So you're going to separate the plasma. Whole blood glucose क्यों नहीं लेते? Because it's affected by the presence of proteins and results in a 15% push downwards of the plasma glucose. Enzymatic methods, yes. So we can detect all our methods are basically based on these few enzymatic reactions only. The most famous one is glucose oxidase peroxidase method. So you have glucose, you have oxygen, you have our enzyme glucose oxidase. It's converted to gluconic acid and H2O2. And H2O2 would further combine with phenol 4-amino antipyrine in the presence of peroxidase to form quinolamine, which we analyze on the spectrophotometer at 505. And then we basically find out what is our blood glucose level. So there are other methods also, which are based on other angles, other enzymes. Now, we all have seen our spectrophotometers. We all know how we calculate concentrations, OD reading of a test on standard into the concentration. Now, so we all know the Beer-Lambert's law and all this. So oral glucose, so the OGTT. Normally individuals, pancreatic insulin secretion maintains the blood glucose in a tight range. Now, if you give anybody glucose load, right, 75 gram for instance, वो कैसे tolerate कर रहा है उस load को is a very important indicator of how the pancreatic health is. So the indication is to clarify borderline elevations in fasting plasma glucose and where HbA1c is not to be done. So when are we not going to do an OGTT? We're not going to do an OGTT when we've already got two tests of fasting plasma glucose or random is more than the cutoffs, which in our case like 126 and 200. Second is we're not going to do when we have one result in our hands and the patient has symptoms. Third is I've already mentioned anybody in surgery, after surgery, fever, trauma, in any case, you're not going to do an OGTT. Ask the patient to have carbohydrate rich, unrestricted diet 2 to 3 days before the test. No exertion, no smoking, no nothing. Take the fasting venous sample. Zero sample कहते हैं उसको. 75 gram glucose को पानी में मिलाओ, उसको patient को पिला दो. Then after 2 hours, take another venous sample. What do you get? In a diabetic, you would find out कि भाई शुरू से ही it is up and above. Right? In a pre-diabetic, it is never touching any baseline. You given the load, ये देखो either it's not touching baseline. Pre-diabetic में क्या हो रहा है, आपने load दे दिया, बढ़ गया, ठीक है भाई, हो गया, but then after a while it's coming down. Hmm? Normal patient again it's coming down. What is the difference between normal and pre-diabetic? दोनों का जो level है peak same है, but the levels are different of blood glucose. Hypoglycemic में तो we're going down, down, down. Renal threshold is 180. Okay, so these curves पूछा जाता है, ये देखो. So what is happening over here? This is the time and this is the blood glucose. Diabetes mellitus never reaching the baseline. कहीं है ही नहीं, हवा में उड़ रहा है. Moderate भी देखो, never reaching the baseline, हवा में उड़ रहा है बिल्कुल. Your renal threshold को अच्छे से क्रॉस करके. नॉर्मल बंदे में क्या चल रहा है कि नॉर्मल जो है रीनल थ्रेशोल्ड से नीचे ही जा रहा है. ओके, रीनल ग्लूकोसूरिया में क्या हो रहा है कि द थ्रेशोल्ड इटसेल्फ ही कम हो गया, राइट, एंड दैट्स व्हाई यू गेटिंग. सो ये तो भाई तुम स्क्रीनशॉट ले लो. So officially I don't tell you to do this, but look at this. Normal GTT curve. Normal बंदा है, plasma glucose इधर है, urine sugar इधर है, आपने जी glucose का load दे दिया, and after that what happens? You can see over here, normal person may you would never get sugar in the urine. There is no glucose, there is no glycosuria. At any time, be it half an hour, 1 hour, 1.5 or 2, there's never glucose in the urine. But on the contrary, if we look at the plasma glucose level over here, this is because of the glucose load you gave, then it comes down and it comes right down to 90. So peak value at 1 hour, but at the peak, baby, it is below the renal threshold value. And look at the Benedict's, nothing. In IGT, you have your fasting level either to start or at 110, right? 110. Then peak value at 1 hour is more than the renal threshold. So renal threshold ko to par kar gaya hai, but after that, after 2 hours, it's coming down. But if you realize it is not coming down to the baseline level, and sugar is seen in the urine after the plasma value crosses the renal threshold value. Renal glycosuria threshold ही कम हो गया. So normal blood glucose concentration, you have actually a normal peak. It is just like an OGTT, normal curve. But एग्जाम में बहुत पूछा जाता है. Urine sugar अगर आपने miss कर दिया इधर से, you will not be able to diagnose. Right? In a normal curve, this is negative, this is negative. In a renal glycosuria curve, this is positive and positive. Okay. So we've already discussed what are our criteria. And these are the OGTT cutoffs at 2 hours. So, and how do you do urine analysis of glucose? It's going to be discussed in your practical classes, how you do Benedict's. So, आपने किया भी होगा in biochemistry. So, I'm not going into all this strip test and all this. How do you test ketone bodies, urine, blood, breath test? Beta hydroxybutyric acid. So whenever you're asked for that diagnosis of diabetes, you are going to have to mention all this. शुरू में जो बताया था OGTT का cutoff diagnostic criteria, then you can mention the urine analysis, what all you're looking for in diabetes, how you're going to do the tests, right? And proteinuria also is important because of diabetic nephropathy. We have proteinuria, so it's the first sign of renal complication. And normal excretion of proteins is less than 30 milligram. You can detect it by strip, you can detect it by our test tube methods. Microalbuminuria is extremely important. Examiners ask it 30 to 300 milligram per day in a 24 hours collection is actually diagnostic microalbuminuria, which is the first indicator of very early diabetes. When the GFR is normal, when the renal damage hasn't happened, you get this, that means the kidney has started being affected by diabetes. And more significant when you have 2 or 3 samples which have been positive over the last 3 to 6 months. So you have to keep on following the patient. The heat coagulation test, we all know about this for urine, GDM and OGTT. So you have a one-step strategy that is basically in 24 to 28 weeks of gestation, and you have your various diagnostic values. So I don't think this is click कर सकते हो the various values of actually uh, there are two strategies. So one is when you give a 75-gram OGTT, just like you did for a normal person, right? Then you have a two-step strategy. If you have 60-gram GTT, ले लो. Just a sec. You have to call you 5 minutes and in the middle of a class. ठीक है, okay, okay. Yeah, okay. So then you have 100-gram OGTT. So basically, you are giving varying loads of glucose and you have varying cutoffs for cases of GT. And this is, I think, a little bit too much. It is beyond your this thing. इसको करने insulin assay में आप क्या देख रहे हो? You're seeing whether your insulin levels in the body, what are they're actually, this is not a common test. This is done mostly for a research perspective only, but just for completion, you can just mention the name insulin assay, right? So if you have a fasting insulin level of less than 25, that is considered as normal. Peptide assay, which is actually an indirect indicator of your insulin levels, because we know that insulin is the molecule is itself bound to your C-peptide. So this is, you can click this insulin assay versus C-peptide in the various endocrine conditions. This is basically for your MCQs, nothing either nahi pucha jayega. Testing for acute complications, where you have to look at your urine glucose, look at your plasma glucose, do your ABG analysis, do your ketones, and then for your long-term complications, analyze the urine proteins, be it through any method, do your lipid profile. There's something called diabetic dyslipidemia, which is insulin resistance, high TGs, low HDL, sometimes asked as an MCV, the lipid profile का नाम भी mention करना आपने. Then test for glycemic control. We are interested कि पीछे 2-3 महीना patient ने कैसे perform किया. So for that you have glycated hemoglobin and then hemoglobin to which glucose is attached enzymatically and irreversibly. Another one is glycated albumin. Okay. So now look at this. So HbA1c is giving you 3 to 4 months performance. Albumin is giving you 2 to 4 weeks performance. That is why all the clinicians ask you for HbA1c, HbA1c. Okay, so HbA1c is actually going to help you. Now, what is HbA1c? Hemoglobin has a number of fractions, and out of these fractions, there is adult hemoglobin. Adult hemoglobin is actually 90% HbA0, and a very small fraction is HbA1. And HbA1 then has further subtypes. Okay, so HbA1c we are interested in, right? So basically, we are analyzing the 3 months blood glucose control. I've already told you HbA1c is based on HPLC. I've already told you the peak also. There's the P3 peak. And this is self-monitoring. Blood glucose is done through the glucometers. So I don't, आपको एग्जाम में नाम गिनाते जाएंगे. That's about. Okay, children, I think that